SCOHRE, an international scientific association of independent experts on smoking control and harm reduction, seeks an open and constructive dialogue to help come up with a better approach to fight the global burden of smoking. 17 years following the introduction of WHO Framework Convention on Tobacco Control, the prevalence of smoking is falling, but the number of smokers is growing. Smoking cessation and prevention remain the most impactful, cost-effective interventions in medicine, but the global burden of smoking is still growing. We at SCOHRE believe that existing smoking control strategies should be complemented with harm reduction. For example, through alternative, lower-risk products use that will replace conventional combustible cigarettes. Nicotine has an addictive potential but plays a minor role in smoking-related mortality. 15% of global deaths are attributed to smoking. If we eliminate the use of smoking, we may even be able to avoid as much as 90% of all lung cancers. In the EU, 27% of all cancer deaths is linked to smoking. Where cessation repeatedly fails, switching to less harmful products is expected to result in benefits for many smokers. Our purpose is to provide stakeholders with science-based and balanced information on the effects of nicotine, to raise awareness on existing knowledge on tobacco harm reduction, and benefit from already existing solid expertise in many countries, to create more opportunities for education of health policy experts, regulators, and the public, to establish new research to generate more evidence to cast out all doubt. Policies should be evidence-based, and the generation of evidence unrestricted. Join our global network of experts to share experiences and ideas, contribute to design research programs, and find ways to fight the smoking epidemic. SCOHRE, an international scientific association of independent experts on smoking control and harm reduction, seeks an open and constructive dialogue to help come up with
Good afternoon to everybody. I'm John Faropoulos, and I would like to welcome you all to this webinar with the title Towards a Smoke-Free World. Today we must be very excited because we have prominent speakers, 4 prominent speakers that are going to make their comments and their introduction. And they all are from a different field of expertise. They have different expertise. So we should stay, I think, till the end and listen to what they have to say and make a good discussion afterwards. So thank you all again. I think that we can start with Dr. Erik Lund, who is going to make the first presentation with the title All European Policies in Line with the Goal Set for a Smoke-Free Europe. Dr. Erik Lund is a Vice-President of SCOHRE and a Senior Researcher to the Norwegian Institute of Public Health. Dr. Lund, thank you for being here with us. You can have the screen floor. Thank you.
Okay, well, thank you, Janis, and good afternoon to you all. My instruction was to address this question: are European policies in line with the goal set for Smoke for Europe? And the short answer to that is no. I mean, the mean prevalence of daily smoking in Europe is still 20%, and after more than 60 years, so tobacco preventing policies. And in Greece and Bulgaria at the very top here with approximately 40% of smokers. And you can see also Sweden at the bottom, where users more often consume it 4%. But in spite of this rather high prevalence of smoking, there are no lack of strategy plans that aims to eradicate smoking in Europe. And reading these plans is quite a repetitive exercise because they're pretty identical, telling us that the zero vision for smoking will be achieved mainly through intensified use of the traditional punitive means of tobacco control, like stronger regulations, higher taxes, denormalization of smoking, accompanied by educational means, providing more information, stronger warnings on packs, and intensified media campaigns. However, in Europe, in most countries in Europe at least, these traditional efforts of tobacco control will be implemented into a modern society that already has been the recipient for these measures for decades. So we'll be implementing stronger regulations into societies already fairly well regulated. The infrastructure for tobacco control is strong in most, but not all, European countries. We will have tax hikes on products that already appear costly to smokers who are, overrepresented by persons with low income in most countries. And we intend to further denormalize a group that is already feeling stigmatized. Smokers already feel bad about themselves. And we will intensify campaigns to an audience already trained in dealing with unwanted information. And we'll also be putting in more information into population that are already very well informed about smoking is bad. In fact, smokers even overestimate their own risks. So there's no information deficit. So there might be marginal returns from intensifying the traditional means of tobacco control. And moreover, we must also acknowledge that the smokers at the receiving end, they have changed. Compared to the smokers we addressed from the tobacco control movement some decades ago, the remaining smokers have become more resistant, more reactant, more inoculated, and immune against further attacks on their behavior. And as a group, smokers have gone through social class descent in many, many countries and have become overrepresented with persons from vulnerable groups, many with mental disorders and thereby lack of coping skills in quit smoking attempts. But anyway, society has changed and the smokers have changed, but the European tobacco control policy, as expressed in these strategy plans, remains more or less the same. But there are some exceptions, like in the UK, where tobacco harm reduction has been implemented as a supplementary strategy. The authorities have embraced the core principles of tobacco harm reduction into their control strategy by making, low risk nicotine products available on the market. We tax them lower than cigarettes and impose a risk proportionate regulation. And in the UK, they inform smokers about risk difference compared to smoking and advise them and encourage them to switch. But somehow this has turned out to be a controversial policy in most European countries and made a very, very polarized split within the tobacco control community between what we can call the purists, who aim for a totally nicotine-free society, and pragmatists whose goal is to reduce smoking-related diseases. We don't fight the drug nicotine, but the diseases that arise from inhaling the smoke from setting fire to the tobacco. And I thought I'd close my talk this afternoon listing some topics of conflict between the purists and the pragmatists in European tobacco control community. On the left side in this messy slide, you have the topics of conflict and the respective opinions in the two right columns, the purists and the pragmatists. So I'm running through this, starting with ultimate goal of the tobacco policy, which is a nicotine-free society, according to the purists, while the pragmatist goal is limited to reduce smoking-related mortality, as I just said. The purist can accept nicotine only for therapeutic use to cure smoking, while pragmatists believe that there always will be an appetite for nicotine. So the best thing we can do is to find the least harmful uptake. Purists point out that addiction is unacceptable in itself, while pragmatists believe addiction could be acceptable if the health risks are low, as it is with e-cigarettes and snus. And as for nicotine harms, purists underline the fact that nicotine in itself could be hazardous to some groups, while pragmatists, on the other side, accentuate that nicotine in itself play a minor role in the development of most smoking-related diseases, and that the harms are moderate and acceptable. Regulation and taxation of, for example, e-cigarettes should be designed to deter uptake among youth, according to purists, while pragmatists argue for risk-proportionate regulation that could motivate smokers to switch product. And as for risk communication, purists put emphasis to the fact that no nicotine products are risk-free, while pragmatists call attention to the risk difference between burning tobacco and non-combustible products. And risk of novel products could or should primarily be compared to the non-use, stress the purist. Well, that is insufficient, says the pragmatist. The comparator should also be cigarettes or smoking. And in a situation where long-term studies of, for example, e-cigarettes are lacking, the purists point out that health effects are unknown, and therefore the precaution principle should prevail to keep novel products away from the market. Well, in that case, many smokers will die unnecessarily, according to the pragmatist. And finally, for the purists, the nicotine industry is dubious and untrustworthy, while pragmatists seem to think that a wider portfolio of low-risk consumer products from the industry is vital to make cigarettes obsolete. So there you go. This was an overview of some central topics of conflicts which divide us in the European tobacco control community. So I thought this was a starting point for this webinar. Thank you for inviting me, and thank you for listening.
Yeah, I'm sorry. Thank you, Dr. Lund, for this interesting presentation. We will have at the end the time to make questions, I think, after we hear all the presentations. But I would like to ask you just now, what do you think about the next years in Europe? We will be able to quit this traditional, let's say, this obsolete approach that I understand that we're having in so many European countries. How we will develop and proceed with new and with new approaches to reach the changes that you have mentioned?
Well, it's difficult to say what will happen in the future, but I think the science is on the pragmatists' side here. I think more and more important papers are being published telling us about the huge harm difference between the products. And also we have studies on behavior change telling us that if you make e-cigarettes or snus in those countries where snus are legal to sell, make them more acceptable to smokers, tax them lower, inform smokers about risk difference, then the smokers will make the switch themselves. But then we have to make these products available and tell smokers about the risk difference. And up until now, there's been some reluctance to do that. And I think regulators has to be, there has to be informed by scientists. But unfortunately, we have been divided up until now. But as I said, I think more and more papers are coming up in support of the tobacco harm reduction principle. So I think in the long run, I think the pragmatists will prevail. And I think we will implement tobacco harm reduction as a supplementary strategy to curb smoking in Europe.
Okay, thank you. So evidence and science would help change.
I think that's the only way to go.
Our
yes.
strategy.
Yeah.
Yes. Okay. Okay, thank you. We'll have the opportunity to discuss furthermore at the end. So I would like to pass the floor to Professor Zaoutis, who is a policymaker, because he is president of the National Public Health Organization of Greece, and I would like to ask him to make his presentation about the holistic approach in public health and how we can complement our public health strategies to reach this smoke-free world. So Theoklis, you may have the floor, please.
Great. Thank you, Mr. Faropoulos. Thank you to the organizers for the invitation. I'm going to focus a little bit on the role of public health institutes towards the smoke-free world that you're talking about, and how we can assist reaching the goal, but also assist a little bit in this dilemma or contrast that my colleague mentioned, the pragmatists versus the purists, and how the public health institutes can assist with that. But I want to start, because I've been knee-deep in COVID-19 the past few years, in just highlighting that the pandemic, the COVID-19 pandemic, has only made reaching a smoke-free world more significant and important. If we look, and I know initially someone might say, what does smoking have to do with COVID-19? But it has a lot to do with it. If we look at which people were affected most by COVID-19, they were people with chronic conditions. Those are the people who lost their lives. Those people experienced morbidity. Those people had the reduced quality of life due to COVID-19. And if we link chronic conditions, we know that smoking is one of the major risk factors for most chronic conditions in cardiovascular disease, respiratory diseases, et cetera. And given that we are talking about the next pandemic already, and that it's something that is going to happen at some point, just because COVID-19 came along doesn't mean that the next pandemic isn't coming as well, from a different virus, et cetera. So smoke-free world is very important in terms of addressing infectious diseases and what's happened already with the pandemic. Public health institutes have as their one of their major objectives surveillance and data. And I think, again, my colleague mentioned, so evidence and science, and I think something that we can contribute and public health institutes should consider is monitoring tobacco use, and monitoring tobacco use as well as alternatives to tobacco use. The more data we have on use, who's using what, how they're using it, et cetera, the more we will be able to inform science, safety, and public health policy. So I think if we think of public health institutes as epidemiology units, I think the epidemiology of smoking and the epidemiology of tobacco use is a major role that we can play towards the goal of having good data. The types of activities which we public health institutes and public health organizations can lend towards smoke-free worlds include peer educations, mass campaigns, community mobilization at the community level. And we do a lot of that for HIV and sexually transmitted diseases. So I think there are major roles that we can play there as well. If we want to get into sort of the pragmatist versus purist conversation and about risk reduction, most public health policies have to do with risk reduction. And I think that's where I want to sort of focus the last few minutes of what I have to say, is we have sexually transmitted diseases are a big part of our prevention policies in the Public Health Institute. We know that abstinence is not an achievable goal. So what do we do in terms of preventing sexual transmitted disease is we reduce harm or risk. Whether you take PrEP for HIV, where you wear condoms, which are not 100%, but they reduce risk. If we look at nutrition, cholesterol lowering, we don't tell people to cut all cholesterol out of their diets. We tell them to reduce cholesterol, eat healthier, etc. So there are paradigms across the public health spectrum that essentially we've learned that risk reduction is a major stepping stone to eliminating or reducing morbidity and mortality from any one of those diseases. So to me, it makes imminent sense. Yes, I understand we need more data, we need better data on the actual risk reduction and the long-term effects of some of these risk reduction strategies. But clearly public health has worked this way in a number of other areas. And I think towards achieving the smoke-free world, it should think in this way as well. Thank you very much.
Thank you, Professor Zaoutis. You have been to the point talking about harm reduction. And if I could ask you, as you said, in public health, we have so many examples of harm reduction. And I would like to ask you why we have so much resistance in adopting low risk policies or harm reduction to the tobacco and in the field of smoking. Because we can see that there is a bigger resistance in introducing harm reduction policies, especially in other countries. We have made a progress to that by a new law in 2019, but so many countries are having a big resistance in adopting harm reduction policies to tobacco. Can you explain?
Yeah, I think though, if we look historically at some of the policies that are very far reaching, meaning that they involve many stakeholders, et cetera, they've been difficult, not just in tobacco. So when New York City went to ban soft drinks because of the sugar content in schools, it was a major battle, major controversy. If we look at salt reduction policies, it has been very challenging for governments to pass broad salt reduction strategies towards reducing hypertension. So I'm not sure it's just there. Clearly, there are some unique issues related to tobacco, but I think change, especially when there are many stakeholders and in general behavior change is very challenging.
Great. Okay, thank you. We will have the opportunity to discuss further at the end. And now I would like to ask to Professor Andrzej Fal, who is the President, Polish Society of Public Health in Poland. And I would like to ask him to make his presentation concerning how fiscal tools can contribute to tackle the spread of smoking towards a smoke-free world. Professor Fall, you have the floor.
Okay.
Thank you.
Well, thank you very much. Can I be heard? Okay,
Yes.
thank you. So first of all, thank you for inviting me to this webinar. And well, maybe I should have kept it for the discussion afterwards, but let me shortly, briefly, very comment on the two excellent speakers that preceded my presentation. Well, we have the same of discussion being held in Poland for the past 20 years. Although we do not call the first group purists, we call them Talibans, and really the way of arguing is very much the same. And still, I think that I absolutely 100%, if I could, it would be 110% agree that the other group, the pragmatists, I myself consider myself a pragmatist, are close to win because the first group's losing. Recently, 2 months ago, the Polish Academy of Sciences, the Committee for Public Health, just published a report showing that over 28% of the Polish population are current smokers. That means a raise by 4% from the last data we had from 2019, which means that we are not going forward, we making steps back. Well, but let me tell you about several tools, including fiscal tools that we're using. I visited, as you see, 2 or 3 days ago, one of my favorite pages showing how many people are newly born every day or every year, and how many of us die every year. As you may see, during this year, over 33 million new inhabitants appeared in the years because 67 million were born and 33 died. 33 million is more or less the size of Poland. Poland is 37 something million. So a new Poland appeared, and well, that's fine, but the trend is changing, and we all know. Why is it changing? Is it because we spent too little money on the healthcare? Well, we are trying to buy health. Look at the 3 bottom lines. We spending $6 billion daily for health. This is more than for education and military combined. So this is really the highest expenditure that we are facing. Well, and we still keep believing in some countries that we can buy longevity and we can buy the longer life expectancy. Well, more or less, life expectancy is in some proportion to the spending to the healthcare system. If you look at this last year, and when you look at the same data more or less 200 years ago, there is some proportion. But it's clearly visible that the proportions are different. And in none of the cases, the proportion was really 1-to-1. So spending $1 more means 1 year longer, 1 day longer, 1 second longer, whatever. Why? Because we needs to take under consideration worse plaques, of course, but NCDs, The NCDs, the pandemics of NCDs has already been mentioned in the discussion today. So the NCDs as a major risk factor for fatal COVID-19 also has been already mentioned. But we tend to forget about NCDs, and we believe that increasing spending will improve the situation. Look at this graph and look at the spending in all the groups of the country, groups in terms of wealth. So, of course, the high-income countries spend much more, but they also rose by almost 2% of GDP, the spending, in the past 2-3 years, so during the pandemic time. When we look at the health priority and the spending following, we see that governments, especially in high-income and upper-middle-income countries, tend to spend more in proportion to the total expenditure to the health services, to the health market. Well, but there are some compounds of this market, there are some elements that cannot be stopped simply by spending money. Please have a look at the NCDs. So when they do develop, and the definition of the NCD is that's a condition that develops in years. So well, it's quite natural that the amount or the percentage of NCDs in young children or in infancy or even in adolescence is very, very low, and it raises along the lifetime. Namely, people after 40 in Europe are believed to, well, statistically have one chronic condition, so one NCDs, and those 65 plus or 70 plus mostly have one or even two or even three chronic conditions, and well, they coexist. So this shows that we have conditions, we have diseases that develop, and they develop not because the money is not being spent. Yeah, the money is being spent, I showed you that. But they're because we have risk factors that are also changing. Maybe it's not time and place to discuss the original risk factors like malnutrition, lack of clean water, and so on and so forth. But when we look at the major factors, risk factors nowadays, most of them behavioral risk factors, we see that smoking, especially smoking, because this is the session, today's session is all about, led to 100 million deaths in the 20th century. And well, we are afraid that it may lead up to 1 billion of tobacco-related deaths in the 21st century. Of course, it causes the deaths because it's a regular risk factor for several NCDs, including cardiovascular disease, cancer, especially of respiratory tract, respiratory diseases other than cancer, for instance, chronic obstructive pulmonary disease, and so on and so forth. When we look at the deaths in Poland and the special risk factors, please have a look at the upper graph, where we see the risk factor for those who die at age 40, 45. At this age, the major risk factor is liver cirrhosis, which is absolutely 99.9% alcohol dependent. So the leading death cause in these young people, 40 to 45, is alcohol. But also already the second one is mixed alcohol and smoking. But then we have the other smoking-related diseases far away. But when we look at those who die a decade later, so being 50 to 55, we already see that we have ischemic heart disease, mainly cigarette dependent, trachea, bronchus, and lung cancers in the second point, which means that it simply takes a little bit longer for the cigarette-related NCDs to develop, but they cause they are the major cause of death in the population of still working, still young people at nowadays standards, being 50 to 55. These two graphs show clearly that this two behavioral risk factors, excessive drinking and cigarette smoking, are really important in the statistics of death, so in the statistics of longevity. When we look again at the financial side of smoking, we see that in the world, without analyzing subgroups of countries, in the world, almost 2% of GDP per year is being lost due to smoking. Well, this all, of course, combines direct and indirect costs. Direct are those related to treating the diseases, to supporting the patients, but the indirect are lost productivity, absenteeism, presenteeism, well, death itself, and several others. So taken together, we lose almost 2% of the total worldwide GDP because of smoking. When we look only at the Americans, so USA losses, and well, the data come from 5 years behind. Well, these are not data that are being generated every year. It's simply very difficult to calculate this data unless we simply decide to multiply or to go the same schedule and to count it year by year. But it was calculated in 2018, and we see that $240 billion has been spent in healthcare for treating the cigarette-related diseases. And then we have lost productivity, we have lost productivity from premature deaths, and we have the final, so the last but not the least, productivity lost and premature death of those who never smoked, of those who were exposed to second-hand smoking. This is absolutely the only one risk factor, behavioral risk factor, that affects not only those who well, use it, overuse it, misuse it, but also those nearby. Well, we know what to do, and we come again to money, because already in 2018, and the update was published 2 years ago, 2021, well, WHO published a Best Buy book for public health, showing that spending $1 in prevention brings, well, not an error, but a save up of $7 in 15 years. Well, it differs from the risk factor to risk factor. You see that already mentioned fighting with the sodas, with the sweetened drinks or salted food. Well, it's the most effective. It brings all $13 from $1 in 15 years, but also a very profitable is investing in cigarette reduction and harm reduction, because it brings over $7 in the same time span. But spending on prevention is the least popular expense in healthcare. When you see at the data of countries in all continents, from low-income group, a high-income group, and all in the middle, you see that only some of them are really spending enough is over 40 on prevention. Well, I'm a little bit ashamed because Poland is the country that fell most in the world in financing prevention. So maybe the result of raising of a number or percentage of smokers from 24 to over 28% of the general population is a result, well, amongst others, of this reduction. Well, being amongst other public health specialists, well, we do remember that public health shows us and teaches us prevention stages. Well, it's not better of this talk to present the whole pyramids and to analyze what the primordial and what the primary and secondary and so on prevention stages are, but I wanted to focus on two things. First of all, we start harm reduction very early, even though the Taliban do not want to call it harm reduction, because every step bringing us to use reduced harm products is harm reduction. But today I want to focus in the final part of my presentation on the financial tool that we can use for two reasons. First of all, to stop people buying cigarettes because, well, they're not available financially available. Well, frankly speaking, they'll be too expensive for them to buy. And secondly, if we have two products of different harm level, to make, if already, those less harmful, more available. So the regulation, let us name it, and we showed it during one of the webinars, the SCOHRE webinars last year, less harm, less tax. Well, when we use as the cost effectiveness, because we always using the fiscal mechanisms, need to use at the cost effectiveness. Also, without going into details today, I can tell you that all the techniques that we know now, and they are called harm reduction techniques, or promoting harm reduction techniques, or restricting cigarette sale due to increased excise tax, are within the gray field, and the gray field is the cost-effective region. So generally speaking, fiscal prevention has been proven by England, has been proven by Sweden, has been proven by United States to be cost-effective. So those ministers of finances who are afraid of losing excise tax, well, they're simply thinking only about the next year's budget. Because if we looked at the costs that we'll have in the healthcare system, or the indirect costs in 15 years, well, the income of the next year budget will look like peanuts. But, well, nobody has this attitude. Once again, when we look at the products, starting with the regular cigarettes and going with the harm reduction technique, well, we have the smokeless, where we have the snus, we see that the risk of harm compared to combusted tobacco, compared to any, well, let's say regular product, is at least 10 to 20-fold lower. So, which means that the costs, the health risk will also be lower, but it will be lower in a couple of years, not the next year, not tomorrow. And this is the problem, I think, with introducing or effective using of fiscal mechanisms by many of the European governments. So I think that one of the goals that all either Talibans or not Talibans in fighting tobacco or cigarette products will focus on is to convince those decision makers that the financial availability is one of the tools that may lower the future risks and may add up with the harm reduction. I leave you with a couple of thoughts that came to me during preparation of these slides. Thank you very much for your attention.
Thank you very much. Thank you very much, Professor Fall, for your excellent presentation, impressive figures for the financial impact of smoking and the correlation between harm reduction policies with the cost effectiveness of healthcare expenditure. We will come after with, I have a question, but I will leave it after the last presentation of Professor Daphne Kaitelidou, who is a professor of the Department of Nursing at the University of Athens and president of the National Agency for Quality Assurance in Health. Professor Kaitelidou, I'll give you the floor because I don't want to interrupt now the flow of the presentations, because I know you have some very important also data to present. So you may proceed. Thank you.
Thank you very much, Mr. Karol, for the invitation. May I share my slides to start?
Sure.
Please let me know if I did. Can you see it full screen now? So again, thank you in this very, very interesting webinar. So my topic is regarding the information of citizens and the data needed to drive what is quite difficult, the behavioral change already mentioned by the previous speakers. So I will try to approach the topic through the experience of my country, of Greece, sharing some data which is actually unpublished. But let's see how the prevalence of tobacco is in Greece. So already said that tobacco use is the most, maybe one of the most or the most preventable cause of illness and death worldwide. It causes more than 8 million deaths, and it actually kills more people than AIDS, malaria, and tuberculosis, according to what has been noted in a WHO report recent. And it has an enormous economic burden, as already presented by the previous speaker, included loss of production and, of course, environmental health. However, the use of tobacco continues. Nearly 1/3 of adults in the European Union are estimated to be smokers. And as you may see in my slide, the prevalence of tobacco varies among the EU countries, possibly showing the different lobbying power within the countries. And Greece is amongst the highest, presents amongst the highest prevalences. There has been a reduction. However, this reduction was not as fast as we would like it to be to cut the goal set. So in general, in Greece, behavioral and environmental risk factors are major drivers of mortality. Almost 40% of adult deaths can be attributed to behavioral risk factors. And as you can see, 22% of all deaths are attributed to tobacco smoking, including direct but also secondhand smoking. The data refer to 2019. So 1 in 4 adults are daily smokers in Greece. This is, as already said, one of the highest rates in EU. In contrast, as you can see, Greece presents one of the lowest binge drinking rates in adults in EU. We have the prevalence of smoking has declined in the last 2 decades, and back in 2000, it was over 1/3 of the population that were regular smokers. In 2019, this has declined to 1 in 4 Greek adults, which reported smoking daily. But as in many other countries, men are most likely to smoke than women. As expected, According to estimates, more than 62,000 new cases of cancer were reported in Greece in 2020. About 33,000 deaths from cancer during that year. And for men, lung cancer was the main cancer site. So, as I said before, I'm going to share some unpublished data. This data derived from a study at which both university and the Greek Agency of Quality Assurance participated. It was actually an OECD study called PARIS. These are the initials for patient-reported indicator surveys. This program, at which more than 19 countries participate, is actually a collaborative initiative to develop weight and standardized a set of indicators which aim to measure what really matters to patients. So the patient-reported experiences, outcomes, and among others, as you may see, health behaviors and patient ability to adhere to medical instructions were recorded. So smoking is included, tobacco use is included in this survey regarding the health behavior. So I will present some of these data which I think have a special interest. So for the sample, to start with some demographics, as you can see, 55% of the participants were female, and almost 53 were among 45 and 59 years old. And almost all of them, 99% were Greek citizens. 8 out of 10 resided in an urban area. So, regarding tobacco and alcohol use, almost 1 out of 4 smoked a type of tobacco product on a daily basis, and 2 out of 5 had daily or almost daily had smoked a tobacco product. In the past 12 months, in the past years, only 1/3 of the participants had been engaged in a conversation with a health professional about health risks of smoking or using tobacco and possible ways to quit smoking. As for the alcohol use, the situation is not that different, as more than 1/3 of the participants had an alcoholic drink or any kind, at least 1 or 2 days a week. While a conversation about alcohol use had been initiated by a health professional only for 10% of the participants. However, the vast majority of the participants agreed on the importance to be informed about health issues, about ways to keep themselves and their families healthy, about ways to understand their personal health risks, and more than 8 out of 10 actively try to prevent diseases and illnesses and rely on health professionals to manage their health and deal with their concern. However, more than 45% of the respondents were somewhat confident or not at all confident about how to change their habits or lifestyle. And only 11.5% were confident or very confident in using information about the internet to make health decisions. And more than 25%, as you may see, stated that it is not it's not at all easy for them to use their primary care center website to look for information on how to access their services. Finally, only one out of three reported that a healthcare professional often or always talks to them about specific goals for their health, And a bit less than half of them, that's a 45% approximately, got enough support from their healthcare professional, often or always, to help them manage their own health and well-being. So, what is some of the main key messages out of this data is that there is a wealth of data nowadays compared to the past. We have data regarding health behaviors or self-reported experiences, but at least for Greece, as well as other countries, as far as I know, this data is not systematically collected. And if it is collected, many times not always shared with all interested parties or stakeholders. And also, the data is not integrated into everyday clinical practice. So the message, I'm afraid, is not passed to the GPs or other health professionals about how important the health promotion and information about smoking is. So a number of measures and actions have been outlined. I will not stay a lot here because previous speakers have already addressed these frameworks in order to reduce both supply and demand for tobacco use. As I think already stated, they include increased taxes, banning of smoking in public places, banning of advertisements of tobacco, warning public about dangers. But what is also a highlighted strategy is to develop personalized plans in order to help all. And if I may say here, maybe the more vulnerable population groups, like those with mental illnesses, the pregnant, the people with low educational and socioeconomic status, about ways to quit smoking, and about the importance of accessibility to all available services. So it's quite important to raise awareness. This is what people said, the users of the health system said, that they need in order to improve the quality of primary healthcare services and provide smoking cessation counseling. Also, follow-up is quite important. We have to monitor progress. We have to identify challenges timely and enhance motivation, and actually use quality of life assessment and publish data more systematically. So more or less, this is what was pinpointed by a very recent campaign completed by WHO, where the strengthening of monitoring and data is important to guide evidence-based policies, control policies. And I would like to highlight the effective stakeholder engagement. So it's quite difficult if one policymaker, even that's Ministry of Health, to be successful. Cross-sectoral collaboration is needed. We have to address challenges from different points of view, and governmental collaboration usually are much more successful when they are combined with national, but also international partners or initiatives. So thank you very much for your presentation. Of course, I'm here for any questions, Mr. Faropoulos.
Thank you, Professor Katellidou, for the unpublished data that you have shared with us. It would be very useful and interesting if we could have also data from the other countries, but I guess that this will happen shortly when the data, all data will be published, I guess. I don't know if we have, I would like the desk to help me if we have any questions. posed by so far with the hand. From the panel, I don't know if we have some questions to or so some comments to make between us. I have some questions, but I'll let you be the first.
Mhm.
Okay, let me pose some questions because we are very shortly we're gonna be in Panama for the COP10 session, where some serious decisions will be taken from all states participating to COP10 to regulate the tobacco products around the world. So far from the preparation meeting of the COP, we see that there is a trend to equalize all tobacco products. From the discussion and the presentations we had today, it seems that tobacco harm reduction is an opportunity to reduce the burden of smoking, to reduce smoking, and to reduce also tobacco-related diseases. However, WHO does not see tobacco harm reduction as an opportunity, although on the FCTC, the protocol published in 2023, in Article 1, it is mentioned in the terms that tobacco control means a range of supply, demand, and harm reduction strategies that aim to improve the health of the population by eliminating or reducing their consumption of tobacco products. On the contrary, WHO focuses on fighting the alternative tobacco products, sometimes even more than the conventional cigarette. And I would like to ask all of you, according to your opinion, what do we need to do as scientists or societies or countries? What actions do we need to take, and what initiative do we need to proceed with to showcase to WHO the benefits from harm reduction?
If I may, well, I cannot
Yes,
find
of course.
the raise hand sign in my computer, so sorry to cut it without raising hand, but I simply can't see it. Well, thank you for raising this subject, because I think that Panama and all the activities before Panama are the only opportunity in many years where we, those pragmatists who believe that harm reduction is really working, can really influence the regulations, because once it's set, the policy that you just mentioned, making equal all the tobacco products, it will be set for many years ahead. And well, actually, I don't see that anything will be or could be done at that point. Now, looking at the history, WHO has lost a big battle, because even though the number of smokers has been deeply reduced in the United States, in Europe, thanks to alternative products, but thanks also to the public health activities. The total number of smokers in the world has not only not dropped down, it rose in the past years, because, well, WHO didn't have the power to stop spreading of cigarettes in other countries, especially Southeastern Asia. So this fight of WHO, it's to me, to myself, not understandable. And I think that going to all the representatives of the WHO by all the scientific or national, international societies, forming one opinion, saying that either now, I wouldn't say or never, but or in 20 years, so in one generation time, we need to introduce harm reduction in this or another way. Because as you have mentioned in the discussion, there is harm reduction present in drugs, in sweets, in alcohol, in several other products, but not in tobacco. So if we do not speak up together before Panama, after that, it can be too late, especially that, well, as I hear, the European Union representatives that will be at Panama are not consulting anymore with the governments, with member countries. So to me, it seems very dangerous. And if we had a way to influence this, if we could join our forces to at least to try to obtain the result, well, I think this was worthwhile thinking of and worthwhile discussing at least.
I think that we should do this before Panama, during at EU level. I think during the preparation of the common EU approach.
Absolutely.
So we will have to be prepared before at EU level and then go to Panama. But again, I think that within EU level, countries that have good examples of harm reduction and achieve good results and have better figures of prevalence by using harm reduction or lower risk products, like Sweden, for instance, would have to raise their hand and their voice and to give the evidence to the tobacco expert group. And this is another question I would like to ask to Dr. Lund for Sweden, because I think that Sweden will be soon the first country to reach a smoke-free goal of 5% or less on smoking prevalence, even earlier than 2040. And so this example has confirmed that smoking prevalence reduction targets can be achieved by endorsing harm reduction policies and smoking alternatives like snus. And epidemiology shows that snus has now higher prevalence than 20 years ago, and incidence of lung or stomach cancers are even lower. How do you comment on that example?
Well, I think Norway and Sweden might serve as examples of what can be achieved if you make available an alternative recreational non-therapeutic nicotine product like snus on the market. So if you grant some market advantages over cigarettes, like lower tax, allow flavors, allow indoor use, and most of all, make it available on the nicotine market, you inform about risk difference, then the smokers will eventually find their own way and make a switch. So in these two countries, in Norway and Sweden, snus has in fact displaced cigarettes. And the three main mechanisms have been the use of snus in smoking cessation. The second one is uptake of snus instead of cigarettes among tobacco-prone youth who otherwise would start to smoke. And also we see that additional use of snus among smokers reduce their smoking intensity, so reduced consumption. So, I think I would like to come back to the question that you asked, Theoklis, at the beginning. I certainly share Andrei's concern about the WHO. I think they have a very hostile approach towards tobacco harm reduction. It's very unfortunate, even if harm reduction is a core element in tobacco control. So I think we have to perhaps ask why they have such a hostile attitude towards tobacco harm reduction. And I think mainly three things. Because we have prior bad experience with the filter and low tar cigarettes, because they were launched as tobacco harm reduction alternatives way back some decades ago, and they didn't produce any lower harm. The second one is that tobacco industry is behind some of these products, not all. I think 20% of the market of e-cigarettes is from the tobacco industry, but 80% is not. And you know, tobacco industry, they're the good enemy. Everyone then can agree to hate. So they have bad reputation, and so when we can say that these products come from the tobacco industry, I mean, then you lose. And then you have the third factor, I think, the longing for the purity and the perfect. Of course, it's unachievable. But many now see, for example, in my country, in Norway and also in Sweden, they have now succeeded in curbing smoking. So then they say, well, let's now move to the next target, to all nicotine products, because see what we have done with smoking, and they don't accept that snus, in fact, has had a major impact in reducing smoking. They only focus on the traditional tobacco preventive measures. So I think the fight against smoking attributable death has eventually morphed into a fight against all nicotine products, and also they want to punish the tobacco industry, which is quite understandable, and drive them out of the business. So that might be some of the reasons why the resistance from the tobacco, from WHO might be. It's a speculation, but yeah.
It sounds reasonable.
Agreed.
And I have one more question, because as I told you, Greece is, I think, one of the countries that has already adopted legislation about harm reduction on tobacco. And the question is for Professor Fall. That you have mentioned that quitting smoking of tobacco is the only way to limit health damages, but only a 30 or 40% of smokers are successful to this. We as policymakers could encourage the rest of smokers to use some lower risk products if we would have some real evidence that the use of such products have a favorable impact on morbidity and mortality. So according to your opinion, how could we obtain this evidence in the future? I mean, evidence about morbidity and mortality. Thank you.
Well, the only problem with obtaining the evidence is that it takes a lot of time. It takes 10 to 15 years or even longer, because as we said during the talks today, the chronic diseases by definition are those chronic, so they need time to develop. So if we have some real ongoing research and we start looking at people who quit now or who do not smoke now and compare with those who keep smoking in 10, we need 10 years or 15 years to conclude. And this is a good way to go, of course, but we cannot wait with everything else until we find out what the percentages of reduction are. Because as we know, already now, there are products, both heated tobacco, electronic cigarettes, snus, and so on and so forth, that produce or contain much more toxic substances than the regular cigarette smell. So I know that this is not a proof, evidence-based medicine proof, but this is a well-informed assumption that these products should cause less harm to the health of the user because they do not have that many toxins inside. So this is the first thing. Second thing is that, I mentioned during my presentation that possibly smoking cigarettes is the only way when you, being the one who is using a behavioral risk factor or who's exposing him or herself to behavioral risk factor, exposes also bystanders to this risk factor. So even from this point of view, using harm reduction techniques reduces harm if we do not fully agree for those who smoke. So we must agree it reduces the harm for those bystanders. So this is the second thing. And the third, finally, well, I was just thinking about it when you were asking the question. Proving that the techniques lower morbidity is one thing, but second thing is proving that we can lower also the exaggeration, and we can provide a tertiary prevention for those who already are cigarette sick, because it has been proven that cigarette smoke not only causes COPD, so chronic obstructive pulmonary disease, but also causes frequent exacerbation in those who already are sick of COPD. It has been proven that cigarettes not only are the major risk factor for lung cancer, throat cancer, and laryngeal cancer, but they're also the continuous smoking of cigarettes makes these diseases, this neoplasm, proceed more rapidly. So people die faster, and the therapies are less effective. So in this case, we already do have proofs that switching from regular cigarettes to other products may be a tertiary prevention. So at least improving the health status in those sick, prolonging the survival, and prolonging, or well, not prolonging, ameliorating the quality of life, so health-related quality of life. But finally, proving that really a change for the other devices instead of cigarette smoking to 100% prove that it's less harmful and show that the diseases do not develop will take a very long time. Of course, we can switch to animal models. These are easily available, and they are, well, they do not take that long to wait for, to prove. But also animal models, for those who are not pragmatists, will not be 100% proof.
If I may add to that, please.
Of course.
Okay, now, as Andrew was saying, for e-cigarettes, we have the biomarker data, we have exposure data, we have data from animal studies, we have cell studies showing or indicating a huge risk difference between smoking and inhaling aerosol from e-cigarettes. But it's important to remember that for snus, we also have the long-term epidemiological data that this product, the snus, does not lead up to the group of diseases that is attributable to 2/3 of the smoking-related deaths, namely lung cancer and COPD and cardiovascular diseases. So we have, in fact, epidemiologically verified evidence that snus makes up only a minor fraction of the risk from smoking. So I think it's important to, when we argue for tobacco harm reduction, to show the experience with snus in Sweden and Norway, where there have been long-time epidemiological studies on this. We have had snus on the market for 200 years, and we have epidemiological studies started in the 1970s in Sweden. So we have some of these data currently lacking for long-term use of e-cigarettes.
Thank you, Karl, for this one. Yeah, absolutely, you're right. And I think that this is one of the reasons why Sweden and those universities or those places in Sweden that took part in this research that you just mentioned should become the leaders of the movement that we've been talking about. So the movement that should lead the whole Europe to follow, maybe not 100%, because, well, it's always some regular differences, but to follow the way that you are far, far ahead of us in.
Sure.
But we need, well, look, at least we need to try to push everything that way. We're not the only group in Europe, of course. We're not the only people in Europe. But when we already meet and try to discuss this matter and these problems, so let's do something to move things forward.
Thank you both. I can see from the desk that we have a question for Professor Kaitelidou. The question is how we could educate consumers to more healthy behaviors, how we can proceed to that. This is a question for Professor Kaitelidou, but of course you can all have your saying. Thank you.
Yeah, thank you for this question, which I'm afraid is quite difficult to be answered. However, answering from our experience is that health promotion should have a systematic role, and it has to be, it has to have continuity, start early from the school age, which in our case, that was not a successful strategy so far, according to the data presented. So ad hoc health promotion campaigns do not actually yield what is expected. So I would say that the presentation of data, the fact that data is lacking, as already said, is challenging. However, I think that health promotion through a number of engaged stakeholders, and as I said before, systematic actions, periodical systematic actions, may prove more successful than policies that has been adopted from Greece so far.
Thank you. I don't know if Dr. Lund or Professor Fall want to.
Well, like, you know, when we're talking about or trying to move smokers from the very hazardous cigarettes to less hazardous nicotine product to making the switch, there will be structural measures like price differences, putting lower tax on the least hazardous products. And you need to put in place a risk proportionate regulation, where regulation is put in place according to the risk they represent. So structural measures, educational measures in informing about risk difference, and also in fact instructing or telling smokers to switch to lower risk nicotine products by, for example, you could put insert in cigarette packs telling smokers that there are in fact alternatives on the market that you would benefit from if you don't want to quit nicotine. And in that way, I mean, if you use that message channel, the inserts in packs, you will only reach the target group of smokers. So this information will not reach non-smokers, because we don't want non-smokers to believe that these products are risk-free. So I think putting inserts in cigarettes packed would be a very, very effective way of communicating to the target group.
Thank you. Very advanced.
Think, if I might shortly add, I also think that good network of well, advisory points for those who intend to quit, because you mentioned that 30 to 40% of smokers quit smoking. But when we look at some medication or we read about some specific techniques, we hear, okay, well, the effect was 60% quitted. And this is one of the arguments being brought up by non-pragmatists. But short term, so for 1 month or for 2 months, but the rebound is very big. So the real amount is even below 30% in Poland, at least. From those who start, let's say it's 100%, this is the group that wants to quit, only 25% of them in 5 years are the real quitters. So those who quitted. So this is very low, because the others continue smoking and continue smoking the regular cigarettes. Well, it's very important that some of the devices we're talking about can be supportive for those who really want to quit. Karl just was saying about the 3 ways of the success of snoozes. I think that very important is the third part of it, so that using snooze as a dual user together with cigarette smoking was still lowering the amount of cigarettes smoked, so still lowering the level of cigarette toxicity. So even if, we are being told that, well, okay, look, but you cannot say that it helped because he or she is the dual smoker. Yes, but he or she used to smoke, 1.5 pack, and now he or she smokes 5 or 7 cigarettes. Well, this is a huge success. Well, I'm from my first profession. So what I do every day, I am chair of the Department of Allergy and Pulmonary Diseases of the National Institute of Medicine in Warsaw. So one part of the department where I have 40 beds, 25 of them is the pulmonary medicine. Well, let's say 60% of those who are admitted to the ward are those who were heavy smokers in the past, or they continue to smoke even though they are sick.
Yeah.
I think myself, I was a smoker for 25 years. I know what it means.
Yeah, I think the concept of dual use is very important, because that's an argument that is often being used against e-cigarettes and snus, that smokers will end up as dual users. But in fact, we have evidence showing that the dual users will have less consumption of the most hazardous product, the cigarettes. That's one thing. And also we have some evidence that showing that dual use is in fact a transient period. It's an interim period, because it's very normal with dual use. I mean, if you look at NRT, the nicotine replacement therapy, there's a lot of dual use. People use NRTs if they, for a period, they use it like a breathing product when they're on airplanes and can't smoke, they use NRTs. So there's a lot of dual use for pharmaceutical products as well. So this is normal. And evidence from Sweden showing that dual use will have an endpoint in just snus use or quitting both products. So it's very, very few dual users who end up permanently as dual users with the same consumptions of cigarettes as they had before the additional use of snus. So I think dual use is in fact something that we shouldn't be so concerned about, like many are.
Thank you. Thank you all. I don't know if we have any other question from the desk. I cannot see any other question. Okay, so coming to the end of this webinar, I could say that we've put another brick in the wall of knowledge and experience towards a smoke-free world. And I would like to thank the speakers. I would like to thank the audience for being with us. I think that it was worth it, staying with us to the end. We will try to bring all the evidence needed to support harm reduction strategies. And of course, we need the evidence, this evidence from the scientists. I would like to thank you once more for being with us. Have a nice evening. Thank you.
Thank you very much.
Thank you very much. See you. It was a pleasure to meet you again. So see you next time, next conference, or maybe somewhere in person. Okay.
Of course.
Thank you very much. Bye to you all. Bye.
Thank you very much.
SCOHRE, an international scientific association of independent experts on smoking control and harm reduction, seeks an open and constructive dialogue to help come up with a better approach to fight the global burden of smoking. 17 years following the introduction of WHO Framework Convention on Tobacco Control, the prevalence of smoking is falling, but the number of smokers is growing. Smoking cessation and prevention remain the most impactful, cost-effective interventions in medicine, but the global burden of smoking is still growing. We at SCOHRE believe that existing smoking control strategies should be complemented with harm reduction. For example, through alternative, lower-risk products use that will replace conventional combustible cigarettes. Nicotine has an addictive potential but plays a minor role in smoking-related mortality. 15% of global deaths are attributed to smoking. If we eliminate the use of smoking, we may even be able to avoid as much as 90% of all lung cancers. In the EU, 27% of all cancer deaths is linked to smoking. Where cessation repeatedly fails, switching to less harmful products is expected to result in benefits for many smokers. Our purpose is to provide stakeholders with science-based and balanced information on the effects of nicotine, to raise awareness on existing knowledge on tobacco harm reduction, and benefit from already existing solid expertise in many countries, to create more opportunities for education of health policy experts, regulators, and the public, to establish new research to generate more evidence to cast out all doubt. Policies should be evidence-based, and the generation of evidence unrestricted. Join our global network of experts to share experiences and ideas, contribute to design research programs, and find ways to fight the smoking epidemic. SCOHRE, an international scientific association of independent experts on smoking control and harm reduction, seeks an open and constructive dialogue to help come up with a better approach to fight the global burden of smoking. 17 years following the introduction of WHO Framework Convention on Tobacco Control, the prevalence of smoking is falling, but the number of smokers is growing. Smoking cessation and prevention remain the most impactful, cost-effective interventions in medicine, but the global burden of smoking is still growing. We at SCOHRE believe that existing smoking control strategies should be complemented with harm reduction. For example, through alternative, lower-risk products use that will replace conventional combustible cigarettes. Nicotine has an addictive potential but plays a minor role in smoking-related mortality. 15% of global deaths are attributed to smoking. If we eliminate the use of smoking, we may even be able to avoid as much as 90% of all lung cancers. In the EU, 27% of all cancer deaths is linked to smoking. Where cessation repeatedly fails, switching to less harmful products is expected to result in benefits for many smokers. Our purpose is to provide stakeholders with science-based and balanced information on the effects of nicotine, to raise awareness on existing knowledge on tobacco harm reduction, and benefit from already existing solid expertise in many countries, to create more opportunities for education of health policy experts, regulators, and the public, to establish new research to generate more evidence to cast out all doubt. Policies should be evidence-based, and the generation of evidence unrestricted. Join our global network of experts to share experiences and ideas, contribute to design research programs, and find ways to fight the smoking epidemic.